Hello, my name is Malcolm Walker. I'm the clinical cardiologist at University College Hospital, London. Thank you to the organisers for asking me to address this important conference. I only regret that I can't be there with you in person. I've been asked to address the question, can we prevent today's cancer patient from becoming tomorrow's heart failure victim? And we start with a good news story. That survival for adults with cancer is over 10 years in more than 50% of cases. And the situation's even better for children. More than 80% of children with cancer will survive more than 10 years. And you'll see on this graph on the left a number of different cancers and the trajectory for improved survival over time, up to 100% for some cancers. However, this means that cardiologists are seeing increased numbers of patients, cancer survivors with heart failure. And it's estimated that this may account for up to 5 to 10% of the heart failure population. Anthracycline drugs and radiotherapy are the prime culprits here, but newer anti-cancer therapies are producing their own unique problems. The mechanisms behind many aspects of cardiovascular toxicity are not completely understood, so the strategies we have to deal with them are limited. And I would contend that for this difficult problem, we're going to need new approaches. So going back to children with an 80% potential survivor for 10 years, we'll look here at progressive changes in left ventricular function as defined by stress velocity index. At the end of chemotherapy, which is shown at the beginning of this green column, virtually all children, the majority, have a reduction in cardiac function. But over the next 4 years after the cessation of chemotherapy, the cardiac function improves, it becomes normal for a latent period of up to 10 years or so. But then there is a gradual and progressive reduction in cardiac function. And some of this we understand the mechanism. So anthracyclines have a number of different mechanisms, one of which is to bind to the 2-beta isoform of topoisomerase that is found in cardiac myocytes. By so doing, they interfere with mitochondrial function, generate reactive oxygen species, and cause DNA double-strand breaks. You end up with myocytes that are vacuolated with disarray of the microfibrillar arrangement. We know that the type, and these are different ones here given in this little table, the type of anthracycline, they have different toxicities, but there is a very clear-cut dose-response relationship. Toxicity affects young patients and elderly patients more so than the middle-aged. There may well be somewhat distinctive mechanisms between the acute cardiotoxicity and the more chronic problems which derive from accumulation of anthracycline metabolites that cannot leave the cell. There is also a greater risk of toxicity if you have other cardiovascular risk factors such as coronary disease or hypertension. Another situation where the risk of heart failure increases is with combination cancer therapies. So here you'll see in women with breast cancer who receive relatively modest doses of anthracycline throughout their treatment, you will see there's a 4% 5-year risk of heart failure, somewhat above a control non-cancer group. However, when you treat them with the HER2 receptor antagonist, trastuzumab or pertuzumab, you can see that the heart failure risk rises to about 12%. Some of that is understood, the mechanism whereby the HER2 receptors are dimerized, that interferes with beneficial responses to the renin-angiotensin-aldosterone system, so that oxidative stresses are increased or enhanced. A big oxidative stress is produced by anthracycline exposure, and then that is amplified in the presence of these HER2 receptor therapies. So you can see combination treatment with a significant 20% 5-year incidence. So that's anthracyclines, HER2 receptors, but you can see here for the different classes of chemotherapy, there are a number of different manifestations of clinical cardiotoxicity, from acute heart failure, from late heart failure, arrhythmias, hypertension, and something called myocarditis. So I want to just briefly touch on one example. New drugs, the immune checkpoint inhibitors, part of the immunotherapeutic approach to cancer, have been incredibly successful where cancer is concerned. And you'll see here illustrated the effect on a previously very difficult cancer, metastatic melanoma. Treated conventionally, 15% of patients survive 36 months. But with these immune checkpoint inhibitors, up to 60% can survive. However, there are side effects, mostly gastrointestinal, with a low incidence of cardiac side effects such as myocarditis. But you will see here the case fatality rate, if you get myocarditis, can reach 50%. And I'll give you an illustration from our own practice. This is a previously very fit 56-year-old who develops a Merkel cell carcinoma. Initial therapy is unsuccessful, so she switched to combination immune checkpoint inhibitors. She develops fatigue and myalgia with a transaminitis, a very significant rise in creatine kinase, and a very significant rise in troponin. And what this graph shows of her progress, this is a 3-week period here when her troponins were up in the thousands. She was treated with very high-dose steroids with not much response initially, but when mycophenolate and then tacrolimus were added, there was a reduction, and I'm pleased to say that she did well. However, during this period, there's a very significant risk of sudden death, and what came home to us, looking after her, and has been reported in the literature, was a distinct lack of cardiac symptoms. You need to respond early with high-dose steroids to prevent sudden death. And this lady, 3 years on, is alive with her cancer in remission and no cardiac symptoms. We have elected to continue with beta blockade. It's been suggested that you follow a program, might even include endomyocardial biopsy in order to make this diagnosis. So, in general, rather than wait until something like this occurs, is there anything we can do to prevent? So you can assume that a patient about to undergo potentially cardiotoxic therapy is what you'd call a stage A heart failure patient, at risk of heart failure but without structural heart disease. And there is some evidence from the standard class of cardiovascular drugs of some benefit. However, the studies are small, the cancers treated very varied with different cancer therapies. The definitions of cardiotoxicity were different. So the evidence, although suggestive, is not strong. And we do need further prospective, better managed trials for the future. We as cardiologists are very used to statins, and they may have a role in this situation because we know hyperlipidemia may accentuate the immunological inflammatory responses in cancer patients. And there are 2 small studies that suggest that there may be some protection by continuing or introducing these drugs. So you could treat these patients, and it's concluded by this publication from a consensus of experts that this is something to be considered. So is exercise, which has a long history in cancer therapy, going back here to very early studies. And in yellow are individuals who are survivors of childhood Hodgkin's lymphoma who have a lower incidence of cardiovascular events if they exercise 9 hours per week or more, compared to a group that do not. That's true for cardiovascular events and coronary disease. And there's a dose response. The more exercise, the better. So once you have the cardiotoxicity, then what you do is fairly clear. Definitions are difficult. Under 40% or a 15% change, or more recently the adoption of global longitudinal strain with a 12% fall or 5% absolute. If an asymptomatic patient develops any signs of cardiotoxicity, they become stage B heart failure, and they require the evidence-based heart failure specific treatment. To wait until symptoms is not a good idea. It worsens their outlook significantly. And in many instances, you can stabilize these patients, and if so, their cancer therapy can continue with a better outcome for them. Starting early is important. If you delay, the responders reduce to 0%, whereas 60% if you introduce failure therapy within a month. So the consensus gives us these kinds of complex algorithms that I won't go through. But I think we can prevent heart failure developing in cancer survivors, but we need better methods. This area of medicine is too complex to rely on ad hoc presentations. The services need to develop formal systems, which we call cardio-oncology, to undertake the work in close collaboration with oncologists. Meanwhile, before we have definitive prospective trials, we need to apply the remedies we know that help in these sort of circumstances: risk factor control, exercise, and appropriate medication for any degree of heart failure. And these have to be introduced early to make a difference. Thank you very much for listening.